we'll be going through, yes, we'll be going through this roadmap for today's session. I think within the next 1 hour, 15 minutes max, we should be done. So we'll look at, just do a bit of an introduction, and then we'll look at human error theory. We'll talk about why nurses make mistakes, even the good ones. We'll also talk about designing against error. We'll do a short group exercise, and then we'll do our key takeaways and wrap up. So why this topic is very important to me. Sorry, let me put off my video just so that I can manage my bandwidth a bit better. Yes, so why this topic is important is that it's real that patients are getting harmed, right? WHO says that at least 1 in 10 patients get harmed when they come to the healthcare setting. And many of these harm, over 50% of them are preventable, is what we're seeing from all the research that's been done over the years. Also, the HPC lawyers last year conducted a research as well, and they identified that the 3rd leading cause of death in the US is medical errors. So we can't even run away from errors. I think what this topic is about is how do we error-proof our system? How do we make sure that our staff, are empowered, 1, 2, they have the resources, they have the time to do the best that they can do for the patients that we're caring for. I mean, again, patient safety is about preventing harm to patients. And until we fully live that mandate, then we're not giving the patient the best that they can get from us. Okay. Okay, so the learning objectives for today would be these 5 key things. So we want to understand why competent nurses make mistakes. We want to be able to differentiate the different types of human error. So we'll, of course, go deep dive into the different types, such as slips, lapses, mistakes, and also give you some examples when we say slips, what they mean, when we say lapses, what they mean, and mistakes and all of that. Also, we're going to try to recognize system factors that drive unsafe practices. Because, when things go wrong, the first thing is to say, who was there? Who was there when it happened? Who is to blame? And all of that. And we'll see why that shouldn't be the case, And then also we'll apply human factor principles to redesigning the work that we do as nurses. Also identify and design strategies that help us to prevent errors. So sometimes errors are inevitable, and we have to know that. And we have to be conscious of the fact that things can go wrong. And it's in that consciousness that we can then make ourselves ready to proactively solve problems before they happen. So I have a case scenario here that I'm going to quickly go through, and just so that we can sort of understand why we're talking about this and why it is important. So this case study is about a good nurse and a bad outcome. So a good nurse that, had a bad outcome. So the background here is that the name of the nurse is Amaka. She's a senior ICU nurse with over 11 years of experience. She's clinically competent. She's respected by her colleagues and known for being very meticulous. So on this particular day, which was a Tuesday evening, of course, they had their ICU full. But unfortunately, on that day, 2 other nurses who were supposed to be on shift called in sick. So normally, she should have been taking care of 2 high acuity patients, but then they had to assign 1 more patient to her. And then one of the patients was unstable and on multiple infusions. Now, the patient, who is Mr. Oyekon, who is 62 years old, post-operative abdominal surgery, he was on IV antibiotics. He was on norepinephrine infusion. He had renal impairment and also had multiple medications scheduled for 8 o'clock in the evening. Now, at 7:55, Amaka started to prepare, those medications. Like I said, this patient had multiple drugs going on, antibiotics, everything at the same time. But then she was interrupted multiple times. Okay, so first by a relative who was asking about visiting policy. Second, by an alarm from another patient. Like I said, she was taking care of 3 high acuity patients. So she had to, of course, share her attention between these 3 patients. And then a phone call as well, while she was preparing this medication, came in from pharmacy about a missing drug. Now, despite all of these interruptions, she resumes the preparation for the medication administration. She went to the fridge and picked, and in the fridge there were 2 different doses of ceftriaxone. So ceftriaxone 1 gram and ceftriaxone 2 grams. Now, these medicines are from the same manufacturer and the vials look alike, right? So she selects one, she reconstitutes it and administers it IV. So 30 minutes later, pharmacy calls her to clarify the dosing, right? And then when they reviewed, they identified that she had given 2 grams instead of 1 gram. Now, subsequently, patient develops worsening renal function. Now, as we know, usually when this type of incidents happen, the first reaction is, is she not a nurse? Didn't she go to nursing school? Shouldn't she know better, right? Why was she not careful? Why didn't she check, right? Am I communicating? Are we together, please? Let me be sure.
Yes, we are.
Yeah, so that's usually the reaction when this type of incidents happen. But we have to usually, going forward, we have to dig deeper and examine this deeper. And just to hear from us, do we think that this nurse was incompetent? I don't want to talk alone today. Do we think that she was incompetent? Yes, Ms. Kolajo, please go ahead.
She is competent, but not diligent.
Okay, why do you say that?
As an experienced nurse, she had over 11 years experience in ICU. I believe she should be used to the distractions by now. She's competent but not focused. Not that she's not diligent. She is diligent but not focused. She's had 11 years of experience. She is used to the distractions. Yeah. And because that wasn't the first time of her administering the medication. Mm-hmm. So my thought would be, before you give the medication, to check with somebody or confirm that you are reconstituting the right medication using the prescription given to you. Mm-hmm. So we don't know in this story if she checked the prescription to confirm before she started reconstituting it. So that's why I said, yes, she's competent, but she's not focused. Or otherwise, if they have a process in place regarding IV drug administration, there are some gaps she has missed. Thank you.
Thank you so much, Ms. Bola Kolajo. Any contrary views or any supporting views? Deborah, are you saying something? Seems okay. I see. Oh, Chika, please go ahead. You have your hand raised.
Hey, I am echoing. Okay, good morning.
Good morning.
I love this presentation. Can you hear me well? Am I echoing?
You are still echoing a bit. I think we need to mute. The host needs to mute, I think. But please go ahead. We can hear you.
Okay. I love the last comment about that she should be used to distraction. And that's just it, right? Because you've done this, your brain should be automated. But that is a problem with relying on human beings as a system. Because the only thing that we can count on is that we'll make mistake. And we can never tell when the mistake is coming. Yes, we can depend on our experience, but how about that one time that we're tired, we're sick, we got distracted more than usual, it's not a good day, and then it impacts somebody's life. So that's what I had to add to the comment. Thank you.
Thank you so much, Chika. Thank you. Any other views? Okay, so that's why we are in this session today, right? We can blame human beings only to a certain extent, right? Because a human is a human and we can make mistakes. No human is full error-proof, right? Because we have different things going on through our minds. We have different challenges we're trying to resolve in our minds at the same time. And in this case, for example, her attention was distracted. As I mentioned, there are 3 different interruptions that happened just while she was trying to prepare this medication for this patient. She was looking at the time. It was already 7:55, and she's saying, I have to give my patient their drug by 8. And within the 5 minutes of preparing this, 3 different people called her attention. Of course, there was a slip there because her plan was correct. She wanted to give the correct drug, but her execution failed. Due to, of course, the similar packaging. Could we have stored the medicine separately? Because as I mentioned, the 2 drugs, the 2 doses of the 2 different doses were stored in the same place, right? So her execution failed because of that, the interruptions as well as the similar packaging. Also, we need to be, conscious that, we trivialize it, but interruptions can significantly expose us to unnecessary risk. Right, so evidence shows that interruptions increase medication error risk significantly, and because it's a high-risk procedure, a high-risk activity, you need your full attention whenever you're administering medication. I talked about the look-alike packaging for the 2 medicines. As I said, they're from the same company, so they actually do have similar packaging. There was also this staffing shortage, right? Are you also going to blame Amaka for the 2 people who didn't come to work, who should have been there? Right? We increased her cognitive load. She was supposed to be taking care of 2 patients, but then we added 1 patient to her. And remember that out of the 3, this Mr. Oyeko was very high acuity, very, very high acuity, even compared to the other 2. So we increased her cognitive load, we increased time pressure, as I said, and she couldn't have delivered at her optimum, considering all of those. I already talked about the environmental design as well of the fridge. Also, something else could have helped, maybe barcoding. If we had barcoding, using technology to sort of close that human error gap. That wasn't in place in this case, and it's something that we need to think about in our different. I see a lot of very senior clinicians and senior healthcare professionals here, and these are type of things that we need to think about. So it's not just saying, as an individual, you're supposed to know, or based on your experience, you should have experienced this, you should know, you should be more focused. We can't do that. We have to error-proof our system. What I mean by that is create a system where it's easier to do the right thing and do it right consistently, rather than allowing people to go to do things that that are wrong. Because if you think about this scenario, if we replace Amaka in this story with another nurse who had 20 years experience, who was probably the best nurse in nursing school or best nurse in the unit, under exactly the same conditions, the likelihood that this same error will happen again is there, right? Because the risk was already built into the system based on what I've explained already. So let's move on. So nurses are human, as we've said. There are universal conditions that we need to think about that degrade our performance, even for the best clinicians with the best intentions. As I always tell people when I do trainings, I say I don't think there's any nurse or doctor or clinician or any, somebody working in the healthcare space who decides, okay, I'm waking up this morning, I think my purpose today is to go and look for who I'm going to kill in the hospital. I don't think there's anybody like that, right? People come with the best of intentions, but errors can happen because of these reasons that are on the screen now. So sometimes they're tired, just as Chika mentions. People are working night shifts. It's not normal for a human being to be awake all night and do it for long hours, sleep deprivation. And as I said, it's not just about the work. You're looking at the human being holistically. There are so many other things that people are going through that you're not even aware of that are impacting on their performance and attention, right? So reducing their vigilance, reducing their reaction time, reducing their attention, all those. Also these interruptions, just like in the story that we've just given, frequent breaks in focus, trying to do multiple things at the same time, all of those are also the issues. Also our cognitive overload, right? We cannot overestimate the capacity of the human mind or the human brain, right? We can only think of so much at a time, right? And I think there's another slide that speaks a bit more into that. So we have working memory, right? For you to use your working memory well, you cannot do more than 4 things, or you cannot be thinking of more than 4 things at the same time. If not, you'll drop the ball. You'll forget one thing, okay? So your working memory is finite. You can actually have too much information to process at the same time, which will make you forget certain things that you should be remembering. And that's just human, Again, you're not a computer, so we don't expect you to be 100% all the time. The other thing is time pressure, right? Because sometimes as nurses, we carry on so much, trying to deal with 10 patients at the same time. There's rush. Everybody's medicine is due by 10 at the same time. The other person is vomiting, you need to rush there to go and deal with that. Another person is having fever, you need to go and tap it sponge. So many different things happening at the same time. So that rushing is constant sometimes, right? So rushing forces shortcuts, because when you are saying, oh, I have to deal with all, okay, let me quickly avoid this, let me quickly skip this process, let me skip that, then you are exposing yourself to making errors, okay? And all of these bypasses are safety checks that we should have in place to error-proof our system. So we need to remember that as humans, as nurses, we are human. So as I mentioned, we're going to talk about the different types of errors. I already explained what a slip is, which is a classical example that we gave earlier. So a slip is an intended action error caused by tension failure, right? Doing the wrong thing. So like this nurse wanted to give ceftriaxone 1 gram. The plan was correct, but the execution was wrong, right? So another example written here is clicking the wrong patient name in a drop-down list because they looked similar, right? Or like we said, picking the wrong medicine from the shelf because they look similar. So for for the slips like this, we need to find a way. So as I said, it's a hard fix of saying, let's separate the storage of these drugs because they look alike. We need to either label them properly and separate them. We need to use Tallman lettering. So the ones that are higher, do Tallman lettering so that people know, or color code it separately. Or different things that we can do to make sure that people don't do the wrong thing just because they are executing wrong. The second one is a lapse. So that's memory failure resulting in omission or forgetting to do something. Again, we are human, right? You can actually forget. It's not intentional that you forget. It can happen because maybe you are dealing with 100 things at the same time. So the example I gave here is omitting an allergy check during a code situation due to distraction, because that's high pressure, high sensitive, high everything at the same time, and you're trying to save somebody's life. You can forget, not because you intentionally wanted to forget, but it can happen. And you must look out for that. Not just with yourself, but also within the team as well. There's the other one that we call mistakes. These are the action goes as planned, but the plan was wrong in the first place. So a patient who, for example, is having fever, and we just assume that the patient has malaria and we're treating for malaria when the patient actually has something else. So yes, the plan was to treat for malaria, however, we're treating the wrong thing. Or like the example here, misapplied the dilution rule because the protocol was misunderstood. So you did something, but fundamentally what you are doing is wrong because you did not plan correctly. That's what a mistake is. And then we have the violation. So violations are deliberate. Violations are you're bypassing the protocol. Your protocol says that for you to administer a high alert medication, you should get somebody else to confirm, get another nurse to confirm, and you say, let's just do it. We've been administering these drugs since nothing happened, so let's just bypass the protocol. So that's an example of a violation. And for this type of one, you really need to coach people and make sure that, we have to apply consequences too sometimes for such cases if people are violating protocol. Okay, so the example written here is bypass barcode scanning because the scanner battery was dead. So they then built a workaround on that because the machine is not working. So let's just go ahead and do it without thinking of what could go wrong with that violation. So these are the different types of errors and just looking at them as examples in practice. So moving on to any questions so far? Am I communicating, please?
Yes, you are.
Thank you very much. So moving on to the Swiss cheese model. Who has heard about the Swiss cheese model before? Any comments here? Okay, no hands raised. So I'm going to go on. Hopefully, if you have any questions, please put it in the chat or raise your hand and I'll call you to speak. Okay. So the Swiss cheese model talks about how our defenses fail It looks at two major areas. So to say we have latent conditions that lead to errors, and we also have, the layers, the actual defenses that prevent these errors from happening. So, for example, like the Swiss cheese slices that you can see on the screen, the slices represent the defenses that we should have in our system, right? While the holes represent those latent conditions that can allow the error to happen. So your defense, for example, your organizational factors, how you've built your environment, how you've employed the correct people, how you've documented your policies, are all the strong defenses. But no one is perfect. No one defense can prevent an error from happening, right? Because it can actually align in a way that it passes through all of these phases or all of these defenses and still gets to the patient. Okay, so we must remember, so like our latent conditions, as we said here, system weaknesses like poor staffing, bad design, training gaps, and all of those things are examples of the latent conditions. So you might have the policy, right, as your defense, but if people don't know the policy, then there's a hole there and things can go wrong. You can have your organization, but maybe you haven't hired the correct people that you should hire. Then there's a gap there, and it will allow the error to pass through, right? So we need to think about it. Again, your defenses can be your technology, as we've said, because you can have an EMR system that prevents people from, documenting the wrong thing. But have people been trained on how to use the EMR system? Do you have a system to make sure that people are complying? Are you auditing periodically to check and give feedback to people on how they can document better, what tools they have available, and all of those type of things to make sure that you have a robust system. So when you have the active failure is when all of the defenses that we've put in place failed, right? Because we allow the hazard to pass through all of them and get to the patient and harm the patient. So harm only happens when the holes in every layer line up momentarily, allowing the hazard to reach the patient. So I have an example on the next slide that talks about an adverse event that happened to a patient. And this is just an example. Yes, this patient had wrong site surgery, but then there were different things that led on to that. It would be easy in this case to say, who is that surgeon that caught this patient or that did this surgery, or who was the theater nurse that was there when this happened? But it's not just about those two people who are at the sharp end of this issue that happened, right? Because there are so many things that would have gone wrong before that stage. And that's where we need to address, or those are the things that we need to address as patient safety professionals. So like in this case, for example, starting from education, starting from even when the consent was filled for this case, somebody documented the wrong site on the consent, starting there. One of the clinicians involved, it was their first day at work in the hospital. So they did not really know what the processes were. They were not trained on the SOPs. They did not know that they're supposed to make sure that they get consent and document the correct site and confirm the correct site, all of those. Also, new equipment never in service. People were not trained on the equipment. Band used instead of marking. So the policies specify that they were supposed to mark the site of the surgery from the ward, for example, but then they used the band instead of marking, right? And then whoever applied the band on the wrong place. The video translation of the imaging for the procedure was down as well, because that would have at least, indicated if it was left or right, but that was down, so technology failed as well. And then communication was also a problem, right? In this case, the family members could not speak English and the patient was unconscious, right? So there was no way to confirm. I mean, they definitely would have looked for how to confirm and make sure that we're doing the right thing by probably getting an interpreter, if an interpreter was, or just finding a way around it to make sure that the correct information was obtained. Also, the history and physical for this patient was not verified with the consent that was used at the end of the day for the procedure. So all of these lined up and led to a wrong site surgery being performed on this patient. Okay, again, the purpose of all of this is to sort of reiterate that if something happens or when something happens, it's not just about that momentary point or that time when that thing happens. Things are built up, to allow that incident to happen. And there are so many slices of cheese that we need to think about and strengthen our system really. And just using this and aligning this with the case study that we reviewed earlier, an error is usually not a single failure. As we've said, layers have failed. So like for the previous case study, we looked at staff planning failed because if we had planned properly, even if 2 people didn't show up, what was the alternative, right? If 2 people didn't show up to work, what else? What's the contingency plan, for the staffing? Also, I talked about medication storage design, lack of barcode system, interruption control, forcing function for dose confirmation, and all of those holes aligned in the previous case that we talked about. Would you say there was reckless behavior? No. Would you say that was an intentional violation? No. So, but what that was human error in a poorly designed system, right? And that's, as I said earlier, is a classical example of a system-enabled slip. So many times when incidents happen, or, with these examples that we've given, we tell people be more careful. Would that really work? Is it about being more careful? I want to hear somebody speak now. Why is it that telling people to be more careful cannot work or will not work? Any responses, any comments? Yes, please go ahead, Chika.
Because being careful is not a reliable system, is not predictive. So you're still counting on the human system to say be careful. And there's also an assumption that they weren't careful, right?
Right.
The first time. Maybe they were. Like there is nothing. I think they're just saying something I see it as noise. They're just words. Because it's not going to prevent the next one. It didn't really understand. It didn't tease out what exactly led to this error so that you can actually make corrective actions. And there's no effort in it. So it's just not going to correct anything. So I don't think it's predictive, and I don't think it's reliable. Yeah. Thank you.
Yeah. So yes, according to James Reason, you cannot change the human condition, but we can change the conditions under which the humans work. And that's what we mean by error-proofing the system, right? Humans, we cannot sustain perfect vigilance. There's no human that is perfect. Our attention is limited, it's a limited resource. You can pay attention, but somebody calls you and says something happened at home. Of course, you are not there anymore, we biologically cannot maintain 100% focus for extended periods of time without faltering. That's the human nature. Also, our memory is unreliable, right? We have short-term memory. So you remember today is not a guarantee that you remember tomorrow. Your memory is fragile, right? Interruptions can erase our critical information instantly, right? Leading to omissions and, errors. Also, stress narrows cognition. I did mention earlier that as human beings, we're going through different things in different aspects of our lives. We're under stress. And when we're under pressure and stress like that, you can only see what's in front of you. You are limited in seeing the full picture, right? And you must also know that. And it's not just about you again, it's about the team that you're managing. So you're managing them as humans as well, and knowing that there's nobody who is perfect. Also, safety must be engineered, not demanded, which is why be more careful cannot work, because you can't just say, go and be more careful. Next time, don't do it again. That's not, that can't work, right? Which is what Chika is talking about, to say, you have to engineer it. You have to drill down and find out what really went wrong here. Reliability comes from designing the systems that absorb human error, not from relying on individual heroism. You now say, oh, if Nurse Bola is there, things work perfectly. But if Nurse Jeremiah is there, in fact, that shift is going to be bad. No, you can't have a system like that. We need to have a system that, irrespective of who is there, whether it's Bola or Jeremiah, the system forces them to do the right thing all the time, right? So that's what we need to build. We need to engineer our system. We have to build in reliability into our system. So I did talk about cognitive overload, and according to Miller's law, your mind, your working memory can only capture 4 to 7 items. In fact, in most people, it's only 4 that you can think of. People that say, oh, I am excellent at multitasking is a lie. So your mind can only process your working memory has the capacity of 4 to 7 items at a time. Okay, so nothing like I can do 500 things at the same time is a lie. You will not do one well. There'll be mistakes. Okay, and the reality of our nursing work is, as I mentioned earlier, we deal with a lot. One human being that you're dealing with, you're talking about the nutrition of this patient, you're talking about, family history, you're talking about the current condition that the patient has, so many different things. That's just one patient. And you have to deal with 10 of such patients at the same time, right? So tracking the status of 6 complex patients at once, that's simultaneous patients, it's part of the things that lead to our cognitive overload. Task switching, as I said, there are different things you are trying to deal with for each of them. One person is vomiting here, the other person is, doing something else there, the other person needs medication, the other person is pressing the nurse call bell, so many different things. And you have to stack and stack and stack all of these things and make sure that you're delivering on every single one. So again, we're not Superman. And you must remember that you're not Superman, right? You're human and you can only do so much to get things right. Also, there's the burden of documentation, because sometimes our leaders, and that's why I'm happy that we have a lot of leaders on this call. Sometimes our leaders just focus on, if it's not documented, it's not done, right? But then what is the demand of this documentation burden on our cognitive overload? Because it now seems as if people are more focused on documenting rather than actually the care that they're supposed to administer to the patient. So as leaders, we need to think about, okay, I will need my people to document, because truly, if they don't document, it's not done. Yes. However, you can't say just document. People will now focus on documenting and leave the care that they're supposed to. What you need to think about, how do I make documentation easy for them? These days you now have checklists. All you have to do is tick, tick, tick. Rather than writing essays of what transpired, it's easier for you to, tick the activities that you've performed, select it on the system, rather than having to type everything afresh. So we need to think about ingenious ways, really, to make sure that, yes, people are documenting. However, it's not a burden that then prevents them from focusing on the care that needs to be rendered. Also, there's alert fatigue. We're working in healthcare systems where different alerts are going off. If it's not the nurse's call bell going off, it's the vitals monitor going off, or it's the ECG machine going off. All these things we need to process, because when you hear the alarm, you need to know, okay, this alarm is for this. Yeah, all of those add to your cognitive overload as a person. So again, it's not all gloomy. While we say, a lot of all of these contribute to our cognitive overload, there's a way to deal with some of these things. As I mentioned, how can we make documentation easier? How do we make sure that we are staffing properly to make sure that people are giving their best at every point in time? So one way, and some of the things I put in here, is design. How do we externalize our memory so that people don't have to depend on their memory or their cognitive load to sort of remember what needs to be done for the patient, right? The first one I put in there is use of checklists. As I said, to document, you can easily use a checklist that people just tick, 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 or a checklist that helps people to remember all the different steps of a process, so they don't have to rely on their attention or their own mind to be able to remember what to do, or to their knowledge, or to their based on their past experience. Or no. It has to be standardized, so that if Nurse Bola is there or Nurse Jeremiah, they're following the same checklist. There's standardization, and they don't need to rely on their memory too much. The other thing is automating calculations. For example, a patient who is diabetic, who is on insulin, do I have to come and start calculating, what dose I'm going to give based on the blood sugar level that I checked? If I have to take 5-10 minutes just to calculate, when I have so many other things to do, that's something that we can quickly automate. Have a system where once I see the blood glucose level, I already know what amount of insulin I'm administering, rather than going to go and start calculating. And all of that is adding to the cognitive overload. Also, visual organization helps as well. Organizing our spaces, organizing our stores in a way that things are labeled properly. So when I come, I'm looking for a size 10 catheter. I don't need to scatter the whole store before I find what I'm looking for, right? Visual organization helps. Also, color coding is important as well. And when I'm saying these things, it's not just about the store, it's also about our medication, how we arrange our medication, make things easy, labeled, easy to reach, easy to access, easy to use. All of those things are very important. All of these, when we do that, then it helps to ease the cognitive overload. So moving on to normalization of deviance. This is also, there's something we call a drift, right? People just feel like we've been doing it like this. So that's the best way to do it because it has not given us any problems, right? And I think I have an example on the next slide. So it's just small shortcuts that have become our routine over time because, that's how we've always done it. It's been working, so we'll just continue doing it like that, even though it's a deviance from what the norm or what the standard should be. Okay, it's workarounds that mask our design flaws. Human beings are ingenious. When something fails, the human mind just finds a way to override that because what people are trying to achieve is, I need to get this medication given. I need to get this job done. If this system is not working, I'm going to find a way around it to get this thing done. And if that works, and others can see that it's working, and everybody is doing it and it's working, your mind just, does that override consistently, and everybody just believes that this override is the correct way to do it. Okay, so workarounds mask design flaws. Staff create workarounds to get the job done because we just want to get the job done and move on, hiding the underlying system problem. So as leaders, if you don't do your Gemba works, for example, or drill down to go to where they're actually practicing what the policy says, for example, you will never really know that people are deviating from what the norm should be or from what the standards should be, right? Because from the top, you can see that, everything is going well, but you don't know that these guys have built a whole workaround system around what they're doing. Okay, so success also reinforces these unsafe norms. When risky behavior does not result in immediate harm, everybody just assumes that, it's good, it's working, let's just continue it. Whatever is working, if it's working, don't change it, right? And then action strategy, do not punish the violation, surface, study, redesign the conditions that enable the drift. So for people to drift from the standard, there's a reason why they drifted. Right? In most instances, again, we are humans. We always say, who is the person that started this? Who is the person that is going against the policy? Don't you know the policy? There's a reason why people drifted in the first place, right? So it's not about punishing the violation because next time, if you're not there, they're still going to find another workaround that you're not going to even know about because you caught that one, okay? So it's about saying, okay, why are they doing it this way? Can we strengthen, can we redesign the conditions so that, everybody is happy at the end of the day and we're getting the best and the safest care possible within the team. So as I mentioned, there's an example here that talks about normalization of deviance in nursing practice. So a busy surgical ward frequently delays completing their second independent double check for high alert medication. Because, nothing has ever gone wrong. They just give the medicine and everybody's happy. Patients are okay, everybody's okay. Initially done only during peak pressure when they first started the process. We said we want to be doing double check. Everybody, we're all doing double check. Yes. First phase, when everybody's momentum was high, they were doing it, but the shortcut gradually became routine practice. New nurses adopted the behavior because they were modeling, the senior staff were modeling it. And then over time, skipping the double check seems normal. But giving, insulin, just go and give, it's okay. Nothing is the same one we gave yesterday, right? Just go and give. And efficient rather than risky. When the dosing error eventually occurs, staff are surprised. How come? Right? Yet the unsafe deviation had already become embedded in the everyday workflow. So this is just an example, and this again can apply in all areas of nursing practice, where we just feel because we have been doing it that way, there's nothing wrong with it. That must be the right way. So that's what normalizing deviance is about. And we need to, in our practice, identify these and sort of call everybody's attention to the right way of doing things. There's a reason why there's a process. There's a reason why there's a protocol. There's a reason why we have to do things, following the steps that have been identified as the evidence-based way of doing it, rather than cutting corners. So when we talk about why good nurses make mistakes, there's the production pressure and competing priorities. Well, I think I've explained these already. So many things to do, all of them high risk, all of them high priority at the same time. So the pressure is high. And in many instances, some of these drivers of pressure, staffing shortages, like in the example that we gave earlier, nurse to patient ratios, bed turnover targets. So we say, no patient should stay in the ER for more than 6 hours, right? Or patients should not stay on the ward for more than 2 days. They have to leave. All of those things, that conveyor belt mentality of saying, we're not a manufacturing company where we're turning over patients, right? We have to do things right. And yes, even though we want to be efficient in our work, yes, we want to, render the best care to the most people at the same time, but we cannot compromise safety. I think that's it. While we're doing our bed turnover target, that's fine. But again, we cannot compromise on safety. Also, time to medication KPIs. We say, oh, we must give the medication within 1 hour, we must give it. Again, while we're trying to meet up with this, because again, these are evidence-based targets, right? We're trying to do things correctly so that the patient gets it when they need it the most and all of that. But having said that, you cannot compromise on safety. The necessary checks have to be done, okay? And then sometimes when things go wrong, especially when we don't meet up with turnaround time or timing issues, especially with medication, we say want to penalize people rather than focusing on the necessary safety checks that people had to do, make sure that the patient was safe. Okay. There's also the documentation burden, which I've talked about already. I no need to talk about that again. So the dilemma we have here is, how are we designing our systems? Okay, are we designing our systems for safety, or are we designing our systems for speed? What impossible trade-offs are we forcing our nurses to make daily? Because we've put them in a situation where they just have to do trade-offs to be, to be effective in their work, really, right? And then when production pressure clashes with safety protocols, safety often loses quietly until an error occurs. It's when the error occurs that everybody's consciousness now comes to say, really? Has it been happening like this? Who, and you knew about it as a nurse manager, you didn't say anything, you're responsible. Sack the nurse. Who is the nurse involved? Sack the person, and all of that. Okay. So while we design our systems for efficiency, we must not compromise on safety. Yes, speed is good, but we have to do speed and do it well. And if it's a trade-off, then safety comes first. It's better to do it late than doing it fast and doing it erroneously. Okay. So safety first. Safety first. Safety first. Safety first. Okay. So there's something called system-induced violations, right? When policies and reality conflict. So we have policies that have been written, but then the reality is different from what we have written in the policies. So violations then become our survival strategy, because maybe the policies, for example, are impractical in reality. Maybe when we wrote the policies and now they're no longer relevant, maybe we need to go and review them. Maybe we've put in steps in the policies that do not exist and do not make sense in the current reality. We need to go and review it, right? There's also equipment not being available, supplies poorly placed, or not even being available sometimes. We know the issue with supply chain in this part of the world, right? So sometimes we've said our policy requires that we have this equipment or we have this consumable, and that consumable is not available. So people have to work, they have to attend to the patient, so they will use whatever is available. And that's an example of a system-induced violation. Also, documentation steps that are redundant or cumbersome. So sometimes we say, oh, EMR is not really working well, and you document it in 5 places. You first document it in one exercise book, then you go and document it in nursing record, then you also go and document it somewhere on EMR. All those things make people tired, right? And then they stop documenting the right things. You want documentation, they'll just write 2 lines there that mean nothing, absolutely nothing, because it's cumbersome, it's difficult to do, okay? There's also conflicting workflows between different units. Different hospitals sometimes have they have ICU, they have different parts of the hospital, and then the workflows can clash sometimes. And when they do, there will definitely be system-induced violation. So the insight here is to fix the system barriers before blaming the clinician. Yes, it's easy to point at people that were there when the thing happened. However, again, we have to always look at the system barriers, look at the system issues, look at the system-induced violations before we start pointing fingers at people and sacking them. So safety 1 versus safety 2. So this slide just compares a reactive approach versus a proactive approach to safety. I don't know. I think maybe we can have a debate here to see which one is better. Can you do one without the other? I'm not sure. So, but the reactive approach just focuses on what went wrong. There's absence of, it focuses on absence of accidents or incidents. It investigates failures by doing root cause analysis. And then here, sometimes the humans are the liability. It focuses, because it's reactive, it's saying okay, what happened? Who was the person involved? What transpired? What did you do? So it seems to focus on the human as a liability and the cause of the error. But the proactive approach looks at things differently. So if the question it always asks is, why do things go right? So rather than the negative thing of what went wrong, is why are things going right? Because if you saw 500 patients last month and you had one incident of wrong medication given, meanwhile 500 patients were given medication, many times as leaders, we focus on that one medication that was given wrongly and forget about the 49 other medication, 499 medications that were given right? So as leaders who are into safety, we should look at the proactive approach as well. In fact, that should be the primary way. Because we have set the system right, then when things go wrong, we're focusing on, rather than the individuals, or saying, okay, the system that we've built, what went wrong? What can we do better? Okay, so why are things going right? We have to ask that question. And the definition of safety in the proactive approach is presence of capacity to succeed under pressure. That's the definition of safety here, rather than absence of accidents or incidents. So that is more reactive, right? The proactive way is thinking, okay, how are we making sure that people are able to succeed under pressure? And then the method is about studying everyday work and adaptability. As I said, it's about being involved as a leader, going through, understanding what is happening on the shop floor, helping people to adapt, because again, healthcare is a complex environment. If things are changing, people need to adapt, people need to learn new things. There are different guidelines coming out every day, we need to adapt, okay? And the view of human factor here is that humans are a resource. They're a solution to flexibility, right? Because we know that humans can adapt very quickly. We know that we can use humans to improve the processes that we have. We know that humans are flexible and they can adapt. So we need to use them positively to strengthen the systems that we have. Any confusion so far? There's a message in the chat. Okay. Am I still communicating? Can you hear me, please?
We can. Well, I can.
Thank you. Thank you. I hope that reflects the feedback from others as well. So, okay, human factors engineering simply means designing systems that work with human nature, but not against it, okay? It factors in the fact that humans are fallible. Humans can make mistakes. It understands that we have limitations. We can be fatigued, we can be stressed, we can have limited memory. Reducing reliance on memory through checklists, as we've said, and visual cues, making the right action easy and the wrong action hard. And I have an example as well that sort of brings that to maybe reality. How can we make the right action easy to do and the wrong action hard? Because when you have people doing normalizing variance or normalizing deviations, it's because the wrong thing to do is easy to do. That's why they're able to violate and sort of go past what needs to be done without doing it. Okay, so we need to always think about that to see how can we make the right actions easy and the wrong actions difficult. Make errors visible early and allow recovery before harm. Again, it's about continuous monitoring of the system, being visible as a leader, and sort of getting feedback, reviewing dashboards, understanding what's going on, audits, data, all of that. That way, proactively, you're able to identify issues and solve them before they actually become problems. There are some key frameworks and resources, I think, in their references, and we can look at that later. So an example that I've put in here of making the right action easy and the wrong action hard is concentrated potassium removal from the wards. So before, the vials were available in the wards, in the ward medication fridge, in the ward cabinets, and there was risk of accidental IV push. I always give a story of a patient who we accidentally gave IV potassium to, though the patient was quite sick, but then the patient was having dialysis, I think, and we had he went into cardiac arrest and he needed to be resuscitated. So in the whole process, they wanted to give, I think it was sodium bicarbonate or so, but mistakenly, the patient was given 2 bolus doses of potassium chloride, right? Of course, the patient died, Now I cannot say, of course, there was no autopsy done or anything. I can't say now if it was the potassium chloride or if the patient was going to die anyway because it was quite bad. But again, that called everybody's attention to see there's a problem here. Of course, the initial reaction was, who is that nurse? Sack the person and all of that. But we had to say, no, let's look at this thing afresh. Look at all the errors, look at all the system failures that led to this incident happening. First of all, this nurse that we're talking about came from another unit to support you guys in this unit. Why didn't your own crash cart have it? It's because your crash cart didn't have it that this person had to run back to their unit to go and get it. Now, in the unit where he ran to, or he or she ran to get it, there was poor lighting where the cabinet was placed, right? Aside from that, if you know the vial for potassium chloride and sodium bicarbonate, they are both 10 ml vials and they are similar. Now, by the time we're investigating this incident, we still found vials of sodium bicarbonate, vials of potassium chloride inside the carton of sodium bicarbonate. So the guy, of course, you are trying to resuscitate a patient, high pressure environment, high risk. The guy is just trying to save somebody's life, rushed in there, saw sodium bicarbonate carton, just picked whatever he or she could pick there, ran back to where the other unit to go and help them resuscitate the patient. And that was the error that happened. So we're not looking at all the system failures, but then saying this staff that came to help is the person that should be sacked. So anyway, after this incident, we had to remove potassium chloride from ward stock because it's a high-risk medication, only available in pharmacy, requires controlled dispensing and dilution. It should be diluted by the pharmacist. Wrong action, of course, accidental IV bolus, then became difficult to do because it's not readily available. Before you get to the point of administering it, different people would have gone through that process to confirm that you're giving the correct thing. So again, this is a true life story that happened, but we need to learn from it. And this is just an example of how you can make right action easy and the wrong action hard. So moving on to design principles that we need to think about. Please, any comments so far or questions? Are we still there? Can you still hear me?
Yes, so.
Okay, great. So moving on to—
Yes, we can.
Thank you. So moving on to our design principles, I think we have 5 of them or so. The first one is standardization. I think we've touched on some of these things already, but this is just to make sure that we're all on the same page regarding what needs to be done. So variation creates uncertainty. So when we say variation, it means different things happening differently in different places. That's variation. It creates uncertainty. So but by standardizing our processes, our equipment, we reduce that mental burden that we talked about on nurses and eliminate the opportunities for confusion and errors. Okay, so for example, standardizing our medication trays to say in a medication tray, on the top left corner is where you have this medicine. On the top right corner, we have this medicine. Bottom left, middle row, first middle row, it needs to be clear. We need to organize our medicines in the tray in a way that is identical. And when I say identical, it means if I go to the next ward, they're doing the same thing, so that irrespective of where I find myself as a nurse working in a hospital, if I'm called to come and help out, I'm working with the same flow or the same standard in my mind. Because if I put my hand here to get sodium bicarbonate, then I must be sure that this is where sodium bicarbonate is placed across all the medication trays around the hospital. Also, uniform drug concentrations. You can't have heparin of 10 milligram in one place and heparin of 100 milligram in another place, right? Or insulin of 100 units per mil in one place and another insulin of 10 units per mil in another place, because you are giving people unnecessary mental burden to come and calculate, to first of all look at it and be sure that they are giving the correct one, then to come and start calculating what is relevant for the patient that you're attending to at that time, and all of that, which creates unnecessary delays and also creates room for errors. So uniform drug concentration, it helps us limit high alerts. We have to limit the high alert medication concentrations to prevent calculation errors as well, right? The other thing is about standard crash cart layout, which also, of course, is similar to the medication trays I talked about. So for our crash cart, it needs to be clear where are the consumables, what consumables are in the crash cart. If it's cannulas should be arranged properly by size, the catheters, cannulas, all of those things, the NG tubes, your epigastric tube, all of those tubes that you use for your resuscitation, all of those things should be properly arranged, right? Okay. So yes, so standardization. So from the medication layer, so we can have a layer for medicines, we can have a layer for consumables, we can have a layer for your ambu bag and all those things that come with the crash cart. Okay. Also the labeling conventions. I did talk about the Tolman lettering, especially for medicines that look alike or sound alike, like dopamine, dobutamine, for example. You can put the boots, the boots in capital so that you can see that there's a difference between the one I looked at before and the one I'm looking at now. And also color coding helps as well. I put in an example here. So essentially what we're saying is when we reduce variation, then we reduce our mental load of carrying information and trying to calculate things on the go. And also this helps us reduce errors as much as possible. This is just an example of a medication list that shows, different categories of drugs with different color codes. This is just an example. And again, I talked about Tolman lettering. You can apply Tolman lettering and all of that. And that's an example of a medication tray that is already divided into layers, and you can store your medicines, and label this properly so they know that on the top left, top right, the specific drugs that are in which layer and all that. So it's easy for people to remember and not make errors. The second design principle is simplification. So what this means is, if you want to, achieve a task, can you achieve it in 5 steps rather than 10 steps? That's what simplification is. So when it's complex, it means that it has multiple steps that are not needed, and it breeds error. So by stripping away the non-essential tasks and streamlining our workflows, we liberate cognitive space for critical thinking and direct patient care. So again, it's about removing all the unnecessary steps. If the task I want to do is to administer a medication, why do I need to follow 10 steps when I can actually do it in 3 steps, right? So it's about critically evaluating our workflows to eliminate all the approval layers or handoffs that add unnecessary delays that really don't give us any value. Also, it's about eliminating duplicate documentation. I think I've talked about that already. Pre-build our order sets. I talked about the patient who is diabetic. We can actually pre-build our insulin sliding scale in a way that once people see that, oh, this patient is within this category, okay, this is the next step to take, right? And it's clear. That way they don't need to, stress their minds or stress their brains to be able to calculate the next step of action or next steps to take. Also use smart defaults. We need to configure our systems to default to the safest, most common option. For example, normal saline, reducing click fatigue and decision load. So when we reduce complexity through simplification, we lower our cognitive load as well, and also we ensure safety of the entire process. And I have an example here as well of simplification, which is the insulin administration, as I said. So before, nurses had to calculate the insulin dose manually. You start saying how many IU, how many this, how many that. And then we convert blood glucose using the sliding scale charts. We document on paper, then we now re-enter into EMR, then we retrieve the insulin from multi-dose vial. Then, again, all of these multiple steps, unnecessary calculations and all. Meanwhile, we can simplify the design, right? We can automate our EMR to calculate the insulin dose. Once we enter the blood glucose into the system, it can automatically tell us what the dosage we should give, right? Standardize insulin orders, as we've said, refill the insulin pens. So all you have to do is set the pen, administer, and you don't need to start counting whether it's 10 mils or whether it's 2 mils or something. Also, automatic documentation after administration. The barcoding system can help do that. Also, once you have it, the order sets automated on your EMR system, all the nurse then needs to do is just go and confirm that what the doctor ordered has been given, rather than starting the documentation process afresh from the beginning. Okay, so when we have a simple design, there are fewer steps, less mental calculation, reduced duplication of effort, and then lower error risk as well. So the third design principle that we're going to talk about is forcing functions. We call it poker yoke. So it's about how do we make people do what needs to be done, right? Essentially, how do we prevent them from doing the wrong thing? So forcing functions are the strongest defense mechanism in a safety design because people cannot go against that. That's what a forcing function is. It forces you to do the right thing. So they create a physical or digital barrier that makes it impossible. So for you to say, oh, imagine doing like documentation audit every time you go and tell people, oh, your documentation is not complete, your documentation is not complete, wasting everybody's time in doing audits, when you can set the system to not save, as in for the clinician to not save unless everything is complete, right? That's why we say it's one of the strongest defense mechanisms. So rather than just going back in time to audit what has been done and tell people that their documentation is not complete, you can force the function by creating a system where people must put in what needs to be put in before they can save and close the case for that patient and move to the next patient. That's just an example. Also, things like barcoding for medication administration will help to force the functions, will eliminate all of these human errors of, oh, am I giving to the right person? Am I giving to the right, am I giving the right dose? Am I giving the, we all know the rights of medication administration. Am I giving the rights at the right site? All of those rights, the barcoding can help you confirm most of those. So it requires you to scan both the patient ID as well as the medication, meaning that if you scan the patient and scan the medication, if the patient is not supposed to have that medication, you will not be able to move forward. Okay, so the barcode system will help you confirm that you are giving the right medicine to the right patient before you administer, and also help you document as well. So if they do not match the order, the system blocks the administration, essentially. Okay, there's also the smart infusion pumps. This one guardrails against, giving the wrong dose. So you can have insulin pumps where you put in maybe the glucose level of the patient, and it automatically calculates everything for you. You don't need to go and start entering it manually, right? And it will never accept, a dose that is wrong for the patient, a dose that is too much for the patient or too small for the patient. If something is wrong, the smart infusion pump will pick that up and prevent you from moving. It will even ask you to say, are you sure you want to administer this, right? And, prevents that error from happening. Also, there is the e-prescribing hard stops. We can set our EHR system to prevent ordering medication if, for example, a patient has an allergy, it will flag, that system will flag and prevent you from actually prescribing that, medicine for the patient, because it will keep telling you this patient is allergic to this drug. And because of that, you won't be able to close that prescription. The other one is independent double checks. In as much as we are using technology, as we say, forcing function, most people link it with technology, but there's also the manual side of it where you can say, okay, I've looked at it as a nurse. Can I get another nurse, to double check, the independent double check, or somebody else who was not involved in the process coming to confirm that, you're doing the right thing before you administer. Okay, so we can't run away from that. We still have to rely on somebody else to help us check, confirm the calculation before and verify before we administer medicines. So when there are constraints like this, it makes doing the wrong thing possible, right? And therefore it prevents harm to the patient. So this is just an example of a barcode scanner and a smart insulin infusion pump that we can use. The fourth design principle is reducing interruptions. I think from the story that I told at the beginning, we know how serious interruptions can be. A patient can die because of interruptions. So interruptions break our focus, it wipes our working memory, creates, we need to create protected time zones, right? Or protected zones and protocols. What I mean by that is, on the ward, for example, as nurses, we can say, see, this is our medication administration time. Cannot have visitors on the ward by this time because we need everybody to focus and do the right thing. So no interruption zone, no interruption time, right? So that it allows the nurses to then focus on those critical tasks without dangerous distraction. So the first one there is, like I said, no interruption zone. Some people even wear visual vests. They wear a vest and, the vest, at the back of the vest, it says no interruption. So when you see that person, the person writes do not disturb at the back of their shirt, it means don't ask me any question. I'm trying to do something critical for my patient. Also protected time blocks, as we've said, and then structured handoffs using our SBAR. We all know about our SBAR tools for handing over, so that we're communicating the right thing, we're communicating accurately, we're communicating complete information that is useful for the entire team, and making sure that we're coordinating care in the best way possible. So when we have protected focus, we have our working memory intact, because then you're not trying to process 10 things when you should be processing only 2 things or 1 thing. And then that will lead to safe administration of medicines. So moving on to just culture. Excuse me. So the core principles here would be distinguished behavior. So we need to know, as I said, I talked about different types of behaviors earlier, whether it's different types of mistakes or errors, and whether it's a slip, it's a lapse, it's a mistake, it's a violation. We need to know the difference, right? So that because they are treated differently. Okay. So as this says, we have to use a decision algorithm to determine the response. So if it's a human error, then you need to console the person involved, right? If it was a risky behavior, you need to coach the person and tell the person, you know, the impact of the violations, not necessarily violations now, the risks they are taking, right? And if the person has intentionally violated the process, then that person should be punished because it's a reckless behavior. So as leaders, we can't punish if it's a human error, right? You have to apply the correct response for the behavior, right? So that you can build a system that is reliable and people know that, you know, they can also rely on the system to get, you know, if the system is at fault, then you can't be blaming the individual. If the individual is at fault, you can't be blaming the system. So everybody will take their own accountability essentially and will deal with it accordingly. Also, the focus is on learning. When we talk about the just culture, it's about learning. It's about this, shifting that investigation question from who is to blame to what went wrong in the system. How did our system allow this to happen? What can we do differently to prevent this from happening again? You know, that's the question that we should be asking quality professionals, as patient safety professionals. And also, it's not just about identify or going, you know, reactive and trying to solve problems or identify the issues. It's also about celebrating the near misses, the good catches. You know, somebody was supposed to administer, was it, I can't remember what drug it was now, whether calcium gluconate or something. But the pharmacy supplied potassium chloride, but the nurse caught it. And the nurse said, pharmacy, why are you giving me this? This is not what I asked for. You know, that was a good catch. Imagine if the nurse went ahead and administered, would have been speaking a different story. So we need to celebrate the good catches in near misses, view them as free lessons rather than failures. Also, there is psychological safety, creating an environment where staff feel safe to speak up about risk without fear of retribution. Certainly, this is what we need to build in our system. People should feel free to speak up, because if they don't, they will hide behind that, and things will go wrong. Certainly, things will go wrong. And you would only find things when they've really gone bad. Okay, so but when you have psychological safety, people can foresee things. You can say, look, I'm not comfortable with this. Can we stop? You know, can we go back? Can we review? Have we done all what we need to do? Not in a rude way. And nurses, you know, because we're there, we're strategically positioned as nurses. We know we're there like 100% of the time. All the other people that come through as healthcare professionals just come and go. But we are there 100% of the time, and we are strategically positioned to identify issues even before they happen. And we can speak up and solve a lot of problems, okay? So if workarounds are common, redesign the process to make the right way the easiest way, as we've said. So there's an exercise, I hope we still have time. Maybe let's just discuss this to say, we need to identify risky, can anybody tell me any nursing process, any risky nursing process? I think we've talked about some already. Any risky nursing process, you can either put in the chat or raise your hand, please. Are we still there?
I am.
Yes, we are here.
Yes, I need examples of a risky nursing process. There are so many of them. So I know I've talked a lot about medication administration today. Handovers. There's so many. So I have 5 examples. I think let's just move on because of our time. So identifying the risk processes, right? When we go back, we need to think about what are the risky things that my nurses do? What are the risky things as a nurse? What risky things do I or what risky activities do I perform as a nurse, right? Errors are likely or frequent. So when we say risky, it means that when I'm doing this procedure, the likelihood that errors will happen is there, right? Or frequent, right? And workarounds are a commonplace, maybe because I don't have the resources I need, or I don't have the tools that I need, and I'm boycotting the process. Those are risky procedures. Or staff feel unsafe or hesitant to speak up. That's a risky process. That's a risky process, or it leads to risky processes, right? And when we talk about redesigning the system, we've already talked about standardizing it, simplifying it, forcing functions, barriers, making sure that people know what needs to be done. So I have an example here of patient identification before procedures. So why is this risky? Two different patients can have similar names, right? A patient can move from one bed to another, right? So if you are calling people by their beds or by their room name, that's totally wrong, because if you say patient in bed B6, it can be another patient in bed B6, right? That's why patient identification is very important. Sometimes wristbands are not permanent, right? They can fall off, they can remove, something can go wrong, and they can fall off. Some hospitals don't even use ID wristbands. And then the assumptions by staff, oh, I assume that it's the same patient I attended to yesterday, so that's what I'm going to go with the same idea, because it's the same patient, it's the same bed, or the same patient that I dealt with yesterday, so it must be the same procedure. So here, we've talked about the two patient identifier rule. It's a hard requirement, and it needs to be built into everything that we're doing. Before you carry out any procedure for a patient, you have to find out what is their name, what is their date of birth, not room number. And we make that mistake a lot in many hospitals, because they say D floor bed 6, you know, and then mandatory scanning before the procedure. That's if you have a barcode scanner, better. If you don't have a barcode scanner, please ask and confirm that you are dealing with the wrong. I mean, some patients have had the wrong legs removed. Somebody has had the wrong eye removed, and we've seen these cases globally, right? Also, we talked about forcing function. In this case, what will be applicable is you cannot document the procedure without confirming the patient's ID. Barcode wristbands, as we've said, that would be a way to force function here. Also, standard timeout process, as we know, the WHO surgical safety checklist, if we comply with that, it has all of these things there. So verbal confirmation by the full team, everybody time out, stop what we're doing. Which patient are we attending? What's the name of the patient? Are we on the same page? What procedure are we doing? You know, we need to all be clear before we proceed. And then checklist signed. So when I say check, that's the WHO surgical safety checklist. So it can be done electronically or manually, as long as it's properly done, because sometimes it's just the circulating nurse that is doing the WHO checklist. Only her by herself is asking the question and answering the question by herself. The surgeon has gone ahead with the procedure, and the aesthetist is doing his own thing. Nobody is paying attention. And that's, you know, that's not standardization, right? If we're doing it, we have to do it properly. Then wristband control policy, we've talked about that already. I think there are comments in the chat. Okay, blood transfusion, yes. Discharging patients, yes. Infection control, yes. Patient triaging, yes. Emergency response, yes. IPC, yeah. Thank you. You all are on point. Good. I was worried. I was beginning to get worried. So the second risky procedures, I have 5 that I've put on the slides, and I'll just go through them before we close. One of them is escalation of clinical deterioration. So sometimes our patients can deteriorate, and we need to be alert. We need to know what to do. This is risky because if we delay recognition, the patient will get worse. Patient can die, right? And we need to, you know, it's risky because sometimes we have hierarchy barriers. You have to tell this one, who will tell this one, and who will tell this one, and who will tell. CMO must be aware, CNO must be aware, everybody must be aware. Patient is dying. Patient is deteriorating. We don't have time for all of those hierarchical barriers, right? And we need to strengthen and align on that, what those processes are. Also, the ambiguous threshold sometimes can be a problem. Fear of overreacting. So nurses may feel like, this patient, I'm seeing something here, but well, that's how he did yesterday and it was okay. It's better to say something than not to say something and something goes wrong. Let it be that you escalated and nothing happened, and people came to attend and nothing happened, rather than you not escalating at all. That's the problem, okay? So here we have early warning scoring system. That's how we can strengthen the system, by automating our early warning score system. When you put in your vitals, it should help you calculate what the risk is through the EMR system. right? Color-coded risk levels, which patients are high acuity, which patients are medium acuity, which patients are low acuity. How do I, allocate my nursing resources according to these patients, okay? There's also clear escalation protocol. So rather than saying you must tell this, and tell that, we need to be clear. What are the trigger threshold? At what point should I call? And who should I call? When should I call? All that needs to be clear to the staff who are on the shop floor so that things are done quickly patients is attended to based on when they need to be attended to. Also, the empowerment policy. Anybody can call to say, I'm not comfortable, with what I'm seeing with this patient. Please, can you come and have a look? Anybody, even the smallest nurse, should be able to do that, okay? And then it's no punitive response. It's not to say, that's how this one is always calling us up and down. Can't you just take care of your ward? No, there's no punitive response for such. Even if it's a false alarm, it's better for it to be false, as I said, than for you to put a patient at risk. Also, your automated alerts, the EMR can generate alerts for abnormal vitals, especially when you have your vitals monitors connected to the EMR system that is doing automatic monitoring. You should be able to trigger to say, like in the ICU, you should be able to trigger to say, patient on so bed, or this patient is having, the vitals are crashing or something is going wrong. Also, automatic documentation as well will help. So another example of a risky behavior in nursing practice is intravenous fluid management, right? That's also a very risky one. Sometimes requires complex calculations, titration adjustments. Somebody talked about blood administration. Yes, pump programming errors, similar drug names, and all of those can be an issue because when you are giving somebody an IV fluid, it's going straight to the heart, right? And it can be dangerous. So I already talked about smart pump technology, insulin pumps, infusion pumps. All of those are things that can help us to administer the right dose at the right time, and not overload the patient's heart with medication that they don't need. Okay, so the smart pumps will help you to eliminate those errors. Also hard limits for high-risk drugs like your high alert medications and stuff. Also your standard concentrations, right? So when you have standardized calculations or concentrations, it's easier to follow, right? Avoid your bedside mixing. You want to go and give a medication, you're mixing. No, if we have the standard epinephrine or standard, medicine in the correct dose that is ready to administer, things are a lot easier. Okay, also your independent double checks. As I said, yes, we can do a lot with technology when it comes to safety. However, you cannot eliminate the need for somebody else to double check what you have done, especially when you are dealing with high-risk situations, high-risk medications, and all of that. Also visual differentiation. I think we've talked about color coding, storage areas, how we label, and make sure that everything is easy to use and easy to access. The other one is handing over and shift reports. That's another risky area where things can go wrong. Because if you're not communicating the correct thing or communicating correct information, patient can get harmed, okay? So why it's risky is because you can lose information, people can make assumptions, time pressure is there as well because, oh, we're attending to patients, we want to go and do handover. Oh, the patient needs me. And because of that time pressure, you are only communicating half of what you need to communicate. There are sometimes also distractions as well. That's why it's risky. So when we're talking about handoffs, shift reports, we need to standardize it. I talked earlier about using your ISBAR or your SBAR templates. That way it's structured. That way people remember what to document, right? They don't miss out any important information. Mandatory key fields in the EMR, I also gave that example earlier. Instead of chasing people to go and document the correct thing, set up the EMR in a way that they cannot leave that place without documenting the correct things, and also make it easy. So it's not just about open text fields. You can design your EMR in a way where for you to document, all you have to do is tick, 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 tick. And people have finished and moved on to the next patient, okay? Structured checklists, what I'm explaining now. Environmental controls, sometimes our words are so noisy. All of those things also cause interruptions and distractions as well. Read back confirmation, especially for verbal orders. All of those are part of the things that we need to put in place to make sure that our patients are safe and that we're communicating correctly and listening and hearing the correct thing. So somebody has called you on phone, go and give so patients a morphine, 5 milligram, and you heard 50 milligram. You have to read back and say, please confirm. Did I hear you say morphine 50 milligram or 5 milligram? Let the person confirm before you go ahead. Okay. We've talked a lot about medication administration. I think we've covered everything that is here. Medication is high risk. Everybody talked about it in the chat as well. It's really high risk. We need to try to redesign that process, make it as small, as simple as possible with the fewest possible steps, standardize as much as possible, the concentrations, barcoding if you can afford it, no interruption. As I said, you can schedule your ward to say from 10 to 11 every morning, please, we are giving medicine. No visitor should come here. Ward rounds will start at 11. Allow us to finish administering our medication before anybody comes in. We can set that up. It's to make sure that the patients are safe. Visual cues, we've talked about that. Formal lettering, we've talked about that as well. So leadership, as I said, many of us here are leaders. Everybody is a leader. So we have our responsibilities as leaders. Safety begins with us at the top, okay? The frontline nurses cannot design these processes that they work in themselves. We hold the keys to the resources, the policies, the culture, and we must design the system for them to do the right thing and make it easy for them to do. So designing safer system. Supply chain, right? As I said, supply chain can be a problem. Sometimes you don't have the needed consumables, you don't have the needed equipment, or the equipment is missing one part or the other. Procurement and supply chain can be an issue sometimes for the nurses on the shop floor. So as leaders, we must make sure that they have the resources, that they use. Physical layout is easy to follow. IT is usable, EMR is usable, and then listen to them, right? As I talked about, we need to find out how work is being done versus how we're imagining that work is being done. So it's by going through the Gemba work, to see the real barriers, to see the real challenges on the shop floor. Auditing and monitoring, we can't run away from that. Removing barriers, fund, making sure that we allocate resources properly, simulation trainings, testing, all those things need to happen, and then close the loop as well. So when they give us feedback, so we'll provide feedback, we also need to listen as well, right? And then when we provide feedback to the staff and they give us feedback, we need to work on what they've said and give them, response to say, okay, this is what we are doing about it. This is what we're doing about your concerns, and let it be real rather than just lip service. So what we must remember from this training is that, number one, good nurses make mistakes because we are human, okay? Most errors are system enabled, not character flaws. Okay, blame fixes nothing. You can blame, it's very easy to blame people. You can blame all you want, but it won't solve the problem. The same, if you change the nurses today, the same problem will keep happening, okay? So design is what helps us to prevent harm. And we've talked about different principles of designing and redesigning our system. And then safety is a leadership responsibility. Thank you, everyone. Any questions?
I have a question, or more like contribution also. So thank you, Dr. Vivian, for your presentation. Can you hear me, please?
Yes, I can hear you loud and clear.
Yeah, what I want to say now is more like an heartfelt concern. We're talking about factors, risk, and processes to cover all these things. But now, let's look at it in the real sense, like the practical aspect of it. I think looking at this issue long run, because to me, I see it as a big issue. It has to do with we nurses first. I know that blaming culture, we shouldn't blame ourselves, this and that, but if we see it as our places of work, let us ask ourselves this question: who are we as a nurse? And many a time you will understand, or you will see that there are lots of human factors to this. Many times, let's say you have nurses on duties, maybe night duty, whereby you just have 2 nurses to 24 patients, which out of those 2 nurses, we have a senior nurse and a junior nurse. And you end up saying that, okay, the junior nurse will be the one exposed to do majority of the work, while the senior nurse is sitting down there. I know majority of nurses can relate to what I'm saying. That alone is a big problem in the profession, in which I want to believe that the nurse leaders should be able to take a very rigid and strong footing in that regard. Like, okay, what can we do? Now, many of the things that you've also said as regards building system, this and that, a lot of them, okay, we've built a system, let's follow this protocol, this communication protocol lines, by using SBAR communication, a lot of things like that. How is it sustainable? The sustainability of it still boils down to the leaders, like the ward managers, ensuring that they are doing these things the right way, the actual way that they ought to do it. But you see many a time, you see people with like lackadaisical attitude, and even in quotes, yes, permit me to say, even some of these nurse leaders, you take some things to them, you explain some things to them, but what will be their feedback? Their feedback is not always that encouraging, whereby you as a younger nurse, you just like, let me sit back, there's really nothing that will be done. Or let's say even in an institution whereby things cannot function without the head of that hospital being around. Like, who does that? And when you now meet out with some group or some set of people that they will call themselves protocol or quality assurance set, they are moving around the world, they are okay, what's going on here, and you let them to know there's nothing they can do, this also person is now, and I'll be like, it's always kind of frustrating, and you'll be like, okay, so without this person being on ground, things cannot function, things cannot work. And now if there are issues or errors that happen, it's still the same set of people that will come criticizing and maybe even sacking people. So I think there are a lot of things to it. And even EMR, we have the pros and cons to it. There are disadvantages, there are advantages of EMR itself. And I actually like the aspect of a presentation whereby you made mention of streamlined simplicity, ensuring that it is. But many a time, like the state where I am now, we know that EMR is what is being used. Many organizations are now adopting the use of EMR, but the way they are being built, some of these EMR systems are being built, differs from, let's say, a very well-developed country. How it's being simplified, how is it simplified, how it's being used over there and the like. Like now, you say, okay, people are weary of documentation. Just imagine one nurse to like 25 patients. You've done a lot of things. You've used like 2 hours on medication, maybe another 1 hour, 30 minutes on vital signs, this and that. And you need to sit down and you now start that documentation, And like you said, 2 person just giving like 2 lines of documentation and the likes. And to the extent that even, let's talk to ourselves as nurses, vital signs, TPR, BP, SpO2 and the likes. You just see some nurses careful. You just see some nurses doing only blood pressure with the pulse that comes with the reading. They will not check the temperature. They don't check the SpO2 read. Like it's actually disheartening. And you see that they will not sit down, they want to document, and they'll start falsifying numbers. Meanwhile, this person is pyretic. A lot of things is going on, things that you could have actually picked. Like, I think we just need to sit down, and my recommendation is there should be a training sector or section for nurse leaders in particular. I think they are the one I will try to address this thing to the nurse leaders in particular. What are we doing? Nurses are like, okay, I will do this thing, maybe for a month or so, they will go in line. After a while, they will drop down again. I think there should be a way whereby we actually need to start enforcing nurses to be doing some things, and even the nurse leaders also, like, go for courses, leadership courses, whereby you've been taught about sustainability, you've been taught about strategies, how to handle some set of people, how to do a lot of things. So just to ensure that things, it is all. Just to ensure that things are being done. But I don't know if you actually could relate to what I'm saying, Ultra, but please, I think the nurse leaders,
100%.
yes, we need to now sit down and see what can we do, how should we go about this to make the nursing profession move forward. And I think it should start from the training schools, school of nursing. What you input into these students till now that they are now actually now functioning and working as a nurse, being licensed and all. Like, that accountability check should be there, and I think the nurse leaders has a lot of work to do. And also, both the junior nurses, we are all leaders in our own spaces. I think we need to change. There should be a mindset shift. Thank you.
Thank you, Comfort. The passion you are using to speak is palpable. I can feel it from here. And that's what we need in the nursing profession. You are right, 100% right. When we talk about quality, when we talk about safety, it begins with the leaders. However, we are all leaders, right? So I know it can be frustrating, and you did talk about that, how you are trying to change the system. You're even coming with new ideas because you've done a training, you're coming with new ideas, and the leaders are not even accepting it. Unfortunately, you can only work on yourself, right? And you can communicate as much as you can to your leaders. But I think in that environment, what you can do is, as much as possible, work on yourself. Do what you can do. Be a good example to the others, right? Be a leader in your own capacity. If it's ESBA communication, implement it in your own small department, in your own small way, and start from there. They will see the difference over time, right? Just keep trying to change them, keep trying to communicate without trying to make it seem as if you're trying to overshadow anybody or to, no. It's about how do we change the system? What can we do? What can I do within my own sphere of influence? Because if you look at the big picture and the whole of Nigeria, trust me, you will not even move one step, right? But start small. And I mean, by the time all of us here start small in our different spheres of influence, I think we will make a positive change. There's a senior nurse leader here, Nurse Ms. Bola Kolajo. Please go ahead. You have a comment.
Thank you very, very much, Dr. Vivian, and thank you very, very much for your thought-provoking presentation. I was going in and out of the training, so I'm not sure if you have mentioned this. It's just a small contribution regarding the scenario that you gave us. The first distraction was family asking for the visiting time policy. My own suggestion regarding that is that policy is supposed to have been done proactively. On admission, there should be an information that is given to the family, and it's either going to be written or verbal. And when it is verbal, there should be an evidence that whoever is the next of kin or the nominated person in the family had been given. If that is done, the distraction will be minimal. The distraction will be minimal regarding that. Also, there should be a written down follow-through protocol regarding intravenous medication administration. In this part of the world, I'm not sure if we have that. Most nurses just reconstitute medication based on how my mentor showed me or how my mentor taught me. There's no reference to any book to confirm the reconstitution is done correctly. So that needs to be something that we as leaders must look into so that we have a standardized way of intravenous medication administration. Also, for intravenous medication administration, it should be double-checked. It should be double-checked before it's being given. In a developed world, that is what is done. That is what is done. It's another layer of safety that must be implemented in our hospitals. If we follow this little protocol, we will reduce intravenous medication administration error. We will reduce it because you are conscious of what you are giving, what you are doing. And any nurse that is administering IV or any oral medication must be patient enough to explain to the patient, I am giving you paracetamol orally, 1 gram, 3 times a day or 4 times a day. It is used for your painkiller. to relieve your pain. And these are the side effects expected. Should you have any, please let me know. Those are simple things that we can do that will help us in minimizing all of these drug error. And to Nurse Comfort, thank you very much for your passion about quality improvement. Please keep the fire burning. But the example you were giving about one nurse to 25 patients, I'm not sure if it is in a private hospital or government hospital. I'm not sure if it is the private hospital or government hospital. So, as a nurse, if you are given 10 patients, 15 patients, 20 patients, my expectation would be for you to know what is wrong with those patients. Once you know their diagnosis, you know their acuity, you will know how to plan your work. Yes, it will be overwhelming. I'm not saying it's not going to be overwhelming, but if you know your patients, it will relieve you mentally to be able to concentrate and focus on whatever you are going to do. And whenever you feel tired, please speak up. Don't continue. Just tell somebody to give you 5 minutes to go and have a drink. And if you want to go outside and shout, please do that so that by the time you come back, you are fresh. Thank you.
Thank you so much, Ms. Kolajo. Thank you. And just to add to that, yes, I mean, many times you are faced with situations. You cannot have all the resources you require every time when you need it, right? So yes, you might have 15 patients to take care of, but you need to be able to prioritize. You need to be able to use the resources around you at that time. In such wards, I'm sure they would allow the patient relatives to be around or something. So to say, okay, which one requires my own attention? Which one can I delegate to the nurse assistant? Which part of the work can I delegate to the relative of the patient, including, for example, doing bed bath for the patient? I don't have to do that because I need to put my brain in what's critical, right? So the patient relative can help me do that. But please, as Ms. Kolajo said, we need to speak up. We need to act, act properly with the resources that we have as much as possible. Chika, you have your hand raised. Please go ahead.
Hi, thank you so much for this wonderful presentation. I'm here thinking, how can this be amplified? How do we make sure everybody, hears this talk? Because it's so foundational. It has every single aspect of building a safety culture. And you mentioned it and you presented it so well. So thank you for that. And it's been a really good conversation and contribution from everyone. You mentioned something about violation when we talked about just culture, right? Or before just culture, and then we led to normalized deviance. And there's a suspicion I have that in the nursing world, that we have normalized so many deviances that is now, even though they are violations, right? But we've normalized them so much that we don't actually see them anymore. And again, is rooted in this, again, systemic design where one nurse can have 24 patients. And yes, you can prioritize, you could check acuity, as Mrs. Bola said, and I agree. The other question is, what is the acceptable number? What is if those systems, if they're not there, I as a nurse, I am going to deviate. I am going to normalize some deviation. And I think when we start accepting the consequences of the current design, then we can start to really say, it's no longer, we're not saying, hey, go and change this, but saying when we do this, this is what we can expect. Like, so we can anticipate the outcome of those things. And I wonder if that would be a more inviting discussion for leaders to say, is that what you really want? Because right now we don't think about it. Designs are not intentional. We just come and we do. And the key word is intentionality. What do we want to intentionally design for better patient outcome? I love the conversation. I love the energy here. And I don't know, I know a lot of the people here are leaders. I'm just wondering who has an idea of how we can amplify this talk, because more people need to hear this across the continent. Please give us ideas on how we can spread this further from just within this group. Great talk, great presentation, and great